The stakes for building remote therapeutic monitoring, or RTM platforms, are absolutely massive right now. Today, we're diving into the 2026 Developer's Blueprint. And let me tell you, if you're designing this architecture, the rules of the game have completely changed.
To really grasp why this matters, think about the structural limitation we've been stuck with for years, literally years. Clinicians needed at least 16 days of data transmission and 20 minutes of management time just to bill for their services. It's kind of wild to think about how restrictive that all-or-nothing threshold was. But starting January 1st, 2026, new CPT code updates are totally destroying that barrier. We're looking at a fundamental shift in how RTM revenue is captured, and honestly, how clinical access is expanded for everyone.
So here's our 5-step schematic to future-proof your RTM architecture. Clinical scope and UX, data ingestion, the billing engine, bidirectional EHR, and finally, security and governance. This is the exact sequential developer's blueprint your engineering team needs to capture this rapidly evolving market from the ground up. If you skip even a single step in this tech stack, you're risking severe clinical friction, or even worse, outright billing denials.
All right, step 1, clinical scope and UX. We need to start right at the user level, specifically defining who provides the care and how patients actually interact with your platform.
So, unlike remote patient monitoring, which we usually call RPM, and that's heavily physician-driven, RTM is different. It empowers physical therapists, occupational therapists, and speech-language pathologists as independent billing providers. This is a super crucial distinction. It means your platform's architecture has to inherently support their unique documentation templates, their specific plans of care, and their unique therapy plan modifiers. Listen, if your system just routes data to a supervising physician's chart, you're building it completely wrong for RTM.
Now, because we're dealing with a massive demographic of seniors here, your user experience has to be tailored perfectly. We're talking 16-point or larger fonts, high contrast black text on a white background, and absolutely no medical jargon. Keep it simple. And for the mobile devs out there, please ditch the complex swipe gestures. Give them clear, persistent back buttons. Confusing a senior with visual clutter just leads to patient drop-off, and in the RTM space, patient drop-off literally kills your clinical insight and your revenue.
Moving right along to step 2, establishing data ingestion layers. How do we actually get the data from a patient's living room straight into our system? Well, it's actually fascinating how we capture the data required to prove the therapy is working. Your data ingestion layer must seamlessly fuse two entirely distinct data types. On one hand, you've got active, subjective patient-reported outcomes, things like the PGIS or the PDQ-39 surveys used for Parkinson's disease. On the other hand, you need continuous, passive, objective telemetry, pulling from consumer devices like an Apple Watch or a smart ring. Your APIs literally have to handle both of these in absolute harmony.
So all of this scattered multimodal data coming from the home has to flow into one single unified clinician dashboard. You need to clearly display pain trends, functional improvements, and decision support alerts. Because without this intelligent integration, you're just handing physiotherapists a massive fragmented data dump, and nobody wants that. They need a streamlined workflow tool that allows for rapid escalation and really clear trend review.
Next up, step 3, architecting the billing engine. This is where the magic really happens for a clinic's financial sustainability.
Getting paid without facing compliance risks all comes down to the core business logic of your 2026 engine, and you really need to consider the massive regulatory shift happening right here. Legacy pre-2026 rules demanded that strict 16-day minimum and 20 minutes of management, but the new 2026 codes, they change everything. CPT code 98XX4 now covers short-duration transmissions of just 2 to 15 days, and code 98XX5 bills for 10 to 19 minutes of management. As a developer, you've got to update your time tracking engines immediately to automatically log these new, shorter touchpoints.
And because compliance is just incredibly unforgiving, there are specific billing logic rules you absolutely must hard-code. Your platform has to automatically flag patients who are missing their day thresholds before any claims are generated. But honestly, here's the most important takeaway for you. You must strictly prevent RPM and RTM billing overlap. If your software doesn't automatically catch when both RPM and RTM are being billed for the same patient in the exact same calendar month, your claims are going to face immediate denial. No way around it.
All right, step 4, true bidirectional EHR integration. Let's see how all of this builds into the broader clinical workflow.
Look, a one-way data feed that just pulls demographics in, but forces staff to manually re-enter monitoring outcomes back into the electronic health record, that creates incredibly dangerous clinical friction. And we all know how much everyone hates manual data entry, right? So your architecture demands true bidirectional sync. Monitoring data, alerts, and clinical notes have to write back to the patient's chart automatically. This way, clinicians never have to leave their primary workflow tool just to see your platform's insights.
To pull off that seamless real-time interoperability, you've really got to leverage FHIR APIs. Sure, older HL7 standards can support remote monitoring, but FHIR is the modern standard, custom designed for the internet age. Taking an API-based approach like this allows you to establish the EHR as the single source of truth for the entire care team. It makes your data flow near real-time and, honestly, incredibly secure.
Finally, we reach step 5, security, privacy, and governance. We absolutely have to wrap this entire technical architecture in a highly secure, compliant shell.
Here's the thing. Traditional monitoring happens in a highly controlled hospital environment. RTM, though, that happens over a patient's home Wi-Fi. Because of this, your platform needs non-negotiable, rock-solid guardrails. We're talking strict adherence to HIPAA or GDPR, executing business associate agreements, and implementing heavy data encryption both at rest and in transit. Plus, you need comprehensive, fully documented audit logs for every single data point, alongside automated escalation pathways for any clinical red flags.
All of this tech ultimately ties right back to standardized reporting and value models. Capturing these secure minimum datasets, like functional score changes, exercise adherence, and the exact number of remote contacts, is absolutely essential. It's not just about providing great patient care, it's about proving the clinical and financial value of remote care to payers and policymakers so you can ensure continued reimbursement.
So as we wrap up this explainer, I want to leave you with a critical question to take back to your engineering team. Is your current code base an asset or a liability for 2026? These new RTM codes present a massive opportunity for scalable remote therapy, but that's only true if your technology can actually handle the UX, the data fusion, the rigorous new billing logic, and the bidirectional sync required to pull it off. I challenge you to audit your tech stack against this blueprint today. Thanks so much for joining me on this deep dive.